We are teachers. Even the competition of చిన్న కంపెనీలు వెళ్ళిందంటే నెక్స్ట్ వచ్చే బ్యాచ్ అయ్యో నా సీరియస్ నేర్చేస్తారు కానీ వాళ్ళకు చేయలేకపోయారు కనీసం వాళ్ళ చేద్దాం వాళ్ళలో ప్రసిద్ధి చెప్పిన టీచర్ వాటరే అదే చూసిన అందరూ బస్సులో కూర్చొని ఎవరు ఏమన్నా సరే అస్సలు పట్టించుకోరు. అది యూజర్స్ అంటే అస్సలు
என்னப்பா என்னப்பா
இது இன்னொன்னு காணும்.
அமௌண்ட் வருதா?
எதுடா இது இன்னொன்னு காணும். ஹெட்செட் ஒன்று காணும்.
ஆனமா இல்ல நீங்க முதல்ல மாட்டிதான் இருக்கீங்க. காட்டுங்க காதை.
Good afternoon, friends. Please unmute yourself during the whole CME. Make sure that you are unmuted.
சாப்பாடு எடுத்து சீக்கிரம். இது என்னது?
ನಾನು ಈಗ ಸುಸಿ ಮಾಡಿಸ್ದೆ. ಏ ಕಲ್ಲ ಮಾಡಿದ್ರ ಆಮೇಲೆ ಅಲ್ಲಿ ಬಿದ್ದು ಹೋಗಿದ್ದೀರ್ ಕಲ್ರ ಇಟ್ರು ಒಂದರ ಹತ್ರ ಎಲ್ಲ ಸುಸು ಮಾಡಿ ಇವಾಗ ತಿಂದ್ರೆ.
Good evening, everyone. I request everyone to mute yourself. Request everyone to mute yourself. We'll be starting the meeting within a minute, sharply at 3. So please, during the entire session, please keep yourself muted. Good evening, friends. Is my slides visible? என்ன is it? Yeah. நான் ஆடிபிளான்னு மட்டும் கேட்க சொல்லுங்க. ஆடிபிளா ஸ்லைட் தெரியுதான்னு கேட்க சொல்லுங்க. Yeah. Am I audible? As my slides visible? Post, please inform me. Am I audible? Is my slides visible? Yeah. Good afternoon, friends. At the outset, I like to thank you all for joining the CME on cough. This is going to be simple, scientific, and also going to be a very practical session on how to approach a cough. So if you have any questions during the session, you can put it in chat box. I'll be answering all the questions. So if you have any questions, please put it in chat box. Yeah. Friends, today we are going to talk about a very, very important protective reflex that's called cough. Basically, it is reflex that contributes significantly. Thank you, Arun. Thank you. So, it is a protective reflex that helps innate immunity by enhancing the mucociliary clearance of the entire respiratory system. So, please remember, given that the cough is a protective reflex, it is crucial not to suppress it without identifying and treating the underlying cause. So, the most important thing is, like fever, this is not a disease per se. Cough is a symptom of an underlying disease. In fever, we have to trace the cause of fever and treat the cause of fever, not the fever. Similarly, in cough, we need to treat the cause of cough, not to suppress the cough. With this introduction, let's go to the first slide. So if you look at the pathophysiology of cough, cough receptors are the one that receive these symptoms and then transmit through the afferent nerve, vagus nerve to the medulla oblongata, cough center. So whenever the cough receptor is stimulated, you get a cough. The coughs, you must know where the cough receptors are present. For example, they are in high density in larynx, trachea, and bronchus. As you move away from these three sites, as you go up to nasopharynx, the intensity, the number of cough receptors become negligible. And as you go down to the terminal bronchioles, almost it becomes nil. That's why in bronchiolitis, there is no cough at all. There's only breathlessness, hypoxemia. So in parenchyma, there are no cough receptors. So in pneumonia, you don't rarely get a cough. So the cough receptor presents in other areas other than the respiratory area, pulmonary sites or external auditory canal, esophagus, stomach, pericardium, pleura. So any irritation or an infection or inflammation in these areas can produce cough. The most important thing as practitioner is that you have to, whenever the patient comes to you, you have to ask about the chief complaints. If the chief complaints is a severe cough, probably it's a respiratory pathology. So whenever you see a child, whatever the illness is, you have to make a empirical diagnosis. Empirical diagnosis consists of 4 components. One is an anatomical, second is a etiological, third is a pathological, and fourth is a functional. For example, if the respiratory tract epithelium is involved, if the respiratory tract epithelium is involved, the anatomy is in the respiratory tract. If the infection is due to viruses, it's viral induced respiratory infection. The pathology is inflammation, and sometimes you have a severe illness like hypoxemia. That's a functional diagnosis. So you have to include all these 4 in your diagnosis. Sometimes you do get cough in other areas. For example, there is an irritation in the esophagus, you do get a cough. Or there's a pericarditis, you do get a cough. But the chief complaints will not be a cough. It will be a chest pain or a retching sensation in the stomach or burning sensation behind the sternum. So some chief complaints will be different. So by looking at the chief complaints, you can focus where the pathology is. And please remember, interestingly, there are no cough receptors on the tonsils. When a child comes to you with acute follicular tonsillitis bacterial, invariably we don't have a cough. So this is for the postgraduates who are attending. There are 11 areas of cough receptors, and there is a single afferent nerve, vagus nerve, and the center is in medulla oblongata, and the efferent or vagus nerve, spinal motor neurons, and phrenic nerve. Through these efferent, we get this violent, forceful expiration. The materials are brought out. This is a protective reflex. Having seen this, let's see what are the types of coughs. Based on the duration, for practical reasons, we divide it into 2. One is an acute cough that lasts less than 4 weeks. Most of them are viral in nature. Most of them are upper respiratory in nature. And chronic coughs that last for more than 4 weeks. Most of them are lower respiratory, and most of them are pathological or significant. So whenever you have a cough, please look for clue. History is very, very important. History of contact, history of vaccination, history of a foreign body aspiration. So history plays a very vital role in giving us the diagnosis regarding the cause of cough. Physical examination, I'm sure, for like any other symptom, you have to have a thorough head-to-foot examination in an undressed child. For example, in a child who has a 4 weeks of cough, you can have an impacted foreign body inside a external auditory canal, which after removal immediately cough will subside without any cough syrup. Though CBC X-ray may not give you much of wanted clues, in some rare selective cases, you can get wonderful clues from these 2 investigations. For our clinical purpose, we divide the cough into dry cough and a wet cough. Please remember, in adults, we have productive cough, non-productive cough. Children do not expectorate, so we don't entertain this diagnosis. Always you must look at the triggers. Triggers are very, very important in a cough. You must identify when there is a household trigger, like incense stick or a mosquito repellent, or the timing when the cough is more, when the cough is less, when it is absent. That's very, very important to make a clinical diagnosis of cough. Based on this, let us dive deep into the subject. So, as I told you, acute cough that lasts for 4 weeks. There are about 6 important conditions where you get acute cough. The first and the foremost and the important one is a sudden onset of a hacking cough in a child who was previously all right. Within a matter of seconds, child will have cough. Many times this is without coryza, and sometimes you can get a choking episode or breathlessness. Sometimes you don't get. The first thing that will hit your mind is foreign body. Always ask for history. Sometimes you can get a history in a child less than 3 years of age, where the incidence of foreign body is very high because they all have the habit of putting things into mouthing habits. They'll be playing with peanuts. And physical examination, very, very important in our suspected foreign body. You have to auscultate, look for differential air entry, or you have to auscultate for a stridor, or sometimes you do get a monophonic wheeze, localized, single-pitched wheeze that happens only in one particular site. So that's a monophonic wheeze. And sometimes by doing an X-ray, even with a negative history and a negative physical finding, you can see a foreign body that is causing obstructive emphysema or atelectasis. So foreign body tops the list in acute cough. The commonest cause of an acute cough in young children is a coryza in a well-looking child. Vast majority, in our OPD, 40% of our OPD comprises of cough. Among them, vast majority is upper respiratory viral infections, for which no specific treatment is required. It's a self-limiting. If you treat, it will last for 7 days. If you don't treat, it will last for a week. The third condition is a child with a coryza suddenly developing a barking cough, portions of voice, and stridor, which is called croup. And whenever you see a child who has a less of cough, mild cough, but child is tachypneic, retractions, intercostal, subcostal retractions, and auscultation crepitations, plus or minus wheeze, you have to consider and entertain an important diagnosis called pneumonia. In young children, viral bronchiolitis, and sometimes if there is audible wheeze, polyphonic wheeze, then you must think of asthma. If a child has got rhinorrhea, stuffy nose, sneezing, itching in the nose, with a family history of allergic rhinitis or a wheeze with eczema or atopic dermatitis, you have to make an early diagnosis of allergic rhinitis. They will settle down just with second generation antihistamine. No need for antibiotics. Please remember, in all these conditions, you have to look for the child entire thoroughly, and it's very, very important. Even though if it is a cough, you have to mark the growth chart. Failure to thrive, if it is present, then you are dealing with something, a sinister cough. You have to look for clubbing, you have to look for chest deformity. All these things are very, very important even for an acute cough. Please remember 2 things you must never miss in an acute cough is a pneumonia and a foreign body. But for these 2 things, all other acute cough are easily manageable. So many a times, what starts as acute can gradually, relentlessly progress to a chronic cough. I'm sure that you will agree with me, pertussis, which lasts for around 90 days, is a condition that starts abruptly. Patient has a paroxysmal cough. Sometimes if there is a partial immunity, they may not have whoop. Pertussis is a very, very important disease in our country, particularly after post-COVID, where the vaccination gap is there. Many children did not take 1.5 years booster, 5 years booster, 10-year booster. Pertussis is on the rise. And of course, mycoplasma, we had outbreaks of mycoplasma. It's an organism that's an atypical organism that does not have cell wall, and your conventional antibodies like amoxicillin, amoxicillin, cephalosporin does not act. So they come to you with multiple antibiotics, having received multiple antibiotics. And your voice diagnosis in a preschool child with mycoplasma with other extrapulmonary symptoms, which I'll talk to you later. You can make a clinical diagnosis of mycoplasma and then start with an empirical azithromycin, which the child will respond rapidly. And of course, adenovirus is something that is definitely we should consider. It is an epidemic illness. Last few months back, we had an outbreak of adenoviral infection. Whole OP was full of conjunctivitis, pharyngitis, and cough. So adenovirus is a great mimicker of bacterial illnesses. So this illness we need to always keep back of the mind when the cough starts as acute, becomes recurrently progressing as chronic. And in our country, in particularly young children, you need to keep foreign body for every cough that comes to your child. And moreover, if the cough does not respond to your conventional therapy. And tuberculosis still is an important disease. If you have a child who has got more than cough of more than 2 weeks, fever of more than 2 weeks, weight loss more than 10%, with or without contact with tuberculosis, you must have a high index of suspicion of tuberculosis. You need to bacteriologically prove. That's very, very important. And of course, mediastinal adenopathy is one thing that we need to keep in the back of the mind whenever you get a child with a chronic cough. A very, very interesting fact about pediatric cough is that vast majority of them are due to recurrent viral infections. It starts with the prodrome. Normally, there are more than around 7 to 8 episodes per year. Each episode lasts for around 10 to 25 days. If you calculate the number of days, assuming 8 episodes with 25 days each, you will have around 200 days in a year. That is, invariably, they will have throughout the year cough and cold. So if you ask the parents will come and tell you that my child is having 3 months of cough, 6 months of cough. But what they usually do is they club all the symptoms together. But you have to take a specific, minute, detailed history. You ask the mother, was the child all right in between? The mother will tell, yes, sir. Last month he had cough for 2 weeks. For 15 days he was all right. Then he got a cough like that. So most of the time they are all repeated episodes of different viruses. Many of them are ILI viruses like influenza, para-influenza, adena, Coxsackie, rhino, RSV. All these viruses clubbed together, they can cause repeated episodes of cough. The most important thing in recurrent viral illness is that the growth will be normal, development will be normal, child be healthy, child be active, playful, everything will be fine. But for these recurrent viral illnesses, for which no antibiotics, no investigation, nothing is required, just keep reassuring. As they grow old, they will come out of this illness. Just most important management is reassurance, and you need not start the child on antibiotics or cough syrups. When you look at the dry cough, probably the anatomy is mainly in the upper respiratory. Sometimes you do get a dry cough in lower respiratory like pertussis and asthma, but generally it is dry cough is from the upper respiratory. Most of the time they are all viral or a post-viral. Please remember, friends, you have lots of, now during this monsoon, you have lots of viral infection called influenza that's rampant in the society, and you do have a post-viral period wherein the cough is there. In influenza, there is a rule of 2. That is, incubation period is 2 hours. The fever lasts for 2 days. The cough lasts for 2 weeks. And in severe influenza category C, the asthenia lasts for 2 months. So this is called rule of 2. Even after the viremia disappears, cough persists. So in viral, just a simple honey will take care of viral and post-viral cough. And of course, hyperreactive airway disease, you must have the confidence to say the parents, This is called asthma. If the child is less than 5 years, you have to tell them under 5 asthma. Most of these children outgrow by the age of 8 years. Even here, there is no role for investigations or antibiotics. Another important cough, particularly in pre-adolescents, adolescents in school-going children, is called a habit cough or psychogenic cough. The recent textbook of Nelson says because of the stigma attached to these names, you have to call it as tick cough or somatic cough disorder. Do not use this habit cough. And once again, I want to stress, because the weaning immunity pertussis is on the rise, always you have to keep, whenever you have a child with a dry cough for a longer duration, keep pertussis in the back of the mind. Sometimes if you have a child who is being referred from nephrology department or cardiology department, if you are having a cough of more than 4 weeks, you have to consider the drugs like ACE inhibitors. If you stop them, the cough will disappear. Sometimes you would have given propranolol for a large hemangioma. Propranolol has got the propensity to cause bronchospastic cough. So by stopping propranolol, cough will disappear. And rarely we do get some foreign bodies in the ear causing autogenic cough. It's due to stimulation of the auricular branch of the vagus nerve, that's called Arnold's reflex. Just removal of the foreign body, the cough will disappear in a matter of seconds. So coming to wet cough, which is the pathology is in the lower respiratory epithelium. Sometimes you can have wet cough in the upper respiratory also. For example, a child with a sinusitis going on for a long time can develop a wet cough. So here you need to see whether the child is having a wet cough for more than 4 weeks or less than 4 weeks, whether the growth and development is normal. If these two are normal, you are dealing with a minor illness, that is nothing major, you need not worry. So here, in a normal growth and development with a wet cough, you have to divide them into 2 parts. One is associated with upper respiratory infection, another is without upper respiratory infection. A wet cough with upper respiratory infection lasting for less than 2 weeks is acute viral coryza, no treatment, just honey. A wet cough that lasts for more than 2 weeks with pain on the frontal region or the frontal sinuses or on the maxillary sinuses or on the face with tenderness, with symptoms of upper respiratory infection lasting for more than 2 weeks. Your probable diagnosis is sinusitis. The drug of treatment is amoxicillin for a period of 10 days. A child who has got a normal growth and development with URI that persists beyond 2 weeks. Child is having only upper respiratory symptoms like sneezing, itching in the nose, running nose, sometimes early morning sneezing, with a family history of allergic rhinitis in the parents or sibling, with eczema. These children can develop postnasal drip and they can have a persistent cough of more than 2 weeks. Just a simple second generation antihistamine is sufficient. If the symptoms are persisting, you can use intranasal corticosteroid. In a wet cough that lasts for more than 4 weeks without upper respiratory symptoms, if the child is active, no clinical findings, X-ray is normal, but a wet cough persists beyond 4 weeks, you can have you can entertain a diagnosis of protracted bacterial bronchitis. This is by European Society of Respiratory Infections. So you can make an empirical diagnosis and you can start empirical amoxicillin for 14 days. This is why you need to start amoxicillin is that the organisms are Strep pneumoniae, staph, and non-typable H. influenza, which have propensity to produce beta-lactamases. That's why you are adding clavulanic acid to amoxicillin. It has been given for 14 days. So when you have a wet cough with growth and development that is impaired, that means you are dealing with something serious underlying illness. What you need to do is you need to investigate and you need to refer to a center where there is pediatric pulmonologist. Some of the disease, the child has got a respiratory infection since birth, and child has got clubbing, child has got chest deformity, and the child has got a persistent cough that interferes with the growth and development. In Western countries, they keep cystic fibrosis in the back of the mind. In our country, we need to keep tuberculosis in the back of the mind. But still, when you see such a child, you have to do a simple bedside test. I'll tell you about the simple bedside test later, so that you can do it at the bedside, so that you can guess what is whether the child has got cystic fibrosis or any cystic fibrosis carrier state. So that test is called achogenic Pharma wrinkling test. You have to consider primary ciliary dyskinesia. The symptom is present since birth, and always when the child requires frequent antibiotics, child is getting recurrent bacterial infections. You have to consider immunodeficiency and necrotizing pneumonias and neglected foreign bodies, middle lobe syndrome are the ones you have to keep in back of the mind whenever there is a growth and development involvement. So these children need to be referred to a center, higher center, where there is a pediatric pulmonologist. As I told you earlier, the olden terminology habit cough, psychogenic cough is removed. You have to use tick cough when you see such children, or somatic cough disorder. These are dry cough occurring in school-going children, particularly pre-adolescent, adolescent. The growth and development will be normal, and they are always afebrile. The most important thing is they are absent during play. They are absent during when they are concentrating on TV or cell phone, or they are absent in the night. Very, very important. And sometimes in your clinic, when the parents come and tell you bring a child, and then tell you that my child is having cough, they have seen many doctors, given many antibiotics, many cough suppressants, it's not coming down. What you need to do is you have to ask the child to sit outside for a few minutes. You have a talk with the parents. So you ask the sister to notice what the child is doing outside the chamber. When they go outside the chamber, cough will stop. When they enter the chamber, the cough will restart by looking at you. This is a simple test you can do just by yourself to find out it's a tick cough or a somatic cough disorder. Please remember, this type of cough produces a la belle indifference. This is a French word that's called beautiful indifference. That means child be calm, disproportionate to the severity of the illness. Here, because of the cough, at the end of cough, child be smiling, happy, whereas the parents and grandparents will be unhappy, people around the child. So that's called la belle indifference. Friends, you saw this classical cough, pertussis cough with a woof. So these are coughs that you can diagnose, is written on the face. The moment child enters your clinic consultation room, you can make a diagnosis. But sometimes there won't be any woof, because there are some people in the society who have a partial immunized state. They would have taken 45 days, 75 days, 105 days, and they wouldn't have taken 1.5 years, 5 years booster. These children will have paroxysmal cough, but they will not have woof. But high index of suspicion. What you must do is, whenever you see a child who comes with bouts of cough, with the tears or red eye or vomiting or a bradycardia or a bulging eye that is coming, protruding forward, you can make a diagnosis of pertussis even without a woof. And always ask for a history of contact. Many times they will tell you, my classmate had a cough 10 days earlier. And many times they will tell you they wouldn't have taken pertussis vaccination properly. Most common in adolescent because of the weaning immunity. And the drug of choice as per CDC is azithromycin 10 mg per kg OD for 5 days. Please remember, pertussis can come in neonates, The dose, drug of choice is erythromycin acetylate, 12.5 milligram per kg per dose. 6 hourly. It has been given for a period of 7 to 10 days. Please remember, many times we do IgM pertussis antibody, or many times we do PCR nowadays. So PCR, once it becomes positive, will remain positive even after treatment. Do not repeat a PCR, that will give you confusion rather than clarity. So this is the cough. I'm sure whoever hears this cough will make an easy diagnosis. Okay. Next we see a typical cough. This child has a cough and a breath and a cough and a breath. This is called staccato cough. What is it? This is called staccato cough. So this, by looking breath, 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 this is called staccato. If you see such a child, you can make a diagnosis as chlamydia or a mycoplasma. When it comes to mycoplasma, there are extra respiratory manifestations are very high. Most of these children will come with mucositis. Sometimes they will have mycoplasma rash. That's called mycoplasma-induced rash and mucositis. They can have other non-respiratory findings like hepatitis, nausea, vomiting, diarrhea. They can have arthritis. They can have sometimes meningoencephalitis. Many non-respiratory symptoms will be there. The most important non-respiratory symptom as a clinician you must see is the onset of anemia after the onset of pneumonia, which is classical. I'll tell you later. So sometimes during monsoons in younger children, we get this type of cough. This child has a barking cough, has got an inspiratory stridor, and also hoarseness of voice. This goes to prove that the child has got infection with parainfluenza 1 virus, which is the commonest, and second is stopped by 3, and the third is RSV. Other ILI viruses, as I mentioned, all the 6 viruses can cause croup. So this, most of the time, they are all mild in nature. The pathology is at the laryngeal level. Rarely you get a respiratory distress. So the most important message as practitioners we must know is, whenever you have a child with croup, please examine the child on mother's lap. Keep the child calm. Crying will worsen the croup. Do not use tongue depressor. Sometimes you can have an epiglottitis that is presenting as croup and it will land up fatal. Never use tongue depressor. In mild illnesses or moderate or severe, it's enough if you use dexamethasone, either oral or IM or IV. Oral is better because you are not going to prick. The dose is 0 kg as a single dose. It has got a long action. With a single dose, they become all right. If you want to help the child, you can give humidified oxygen. No need to start an IV line because your unnecessary intervention will worsen the disease. If the child has got a severe disease, hypoxemia, you can use nebulized racemic epinephrine, 2.25%, at the dose of 0.5 ml in 2.5 ml of normal saline. You can give it with oxygen nebulized. It has to be repeated every 2 to 3 hours because of short acting. In croup, please remember, no antibiotics, no sedatives, no cough syrup, no unnecessary interventions. These 4 no's you have to keep in the back of the mind. So just by looking at this cough, you can make a diagnosis. These are all diagnosis written on face. So sometimes you do get children who come to you just by taking a history, you can make a diagnosis. Suppose the mother will tell, whenever my child goes for sports or exercise, running race, he gets a cough. When the child is emotionally disturbed, laughs violently for some time or cries, gets a cough. Whenever there is a rain or an environment change, whenever I take the child in a bike, in a cold wind, child gets a cough. Sometimes during monsoon season, during the month of September, October, during rainy season, my child gets a cough. Sometimes some of the parents will tell when the child takes a seafood or a peanut or a ghee, my child gets a cough. Sometimes some of the parents will get, my child is all right in the daytime. In the night time, particularly after around 12 midnight till morning 5 a.m., early morning, child gets a cough. This is mainly because of the bronchospasm that happens in the night. Normally, you have a cortisol that prevents bronchospasm. This is called circadian cortisol rhythm. This cortisol level is lowest in the midnight. So there is a bronchospasm. So when you get a child associated with these symptoms with cough, ask for a history of atopy in the same child when the child was young, or there is a fractural eczema, or in the siblings, or a family history of wheeze or allergic rhinitis. If they are positive, then your diagnosis is straightforward, simple. It is hyperreactive airway disease. Do not hesitate to make a diagnosis of asthma. You have to tell them it is asthma. So this diagnosis needs only careful history. Without doing lab tests, you can make a diagnosis. The child is more than 7 years. You can do a spirometry, lung function test, and then make a diagnosis. But the test is difficult. You need an instrument and you need how to interpret properly. But childhood asthma is a diagnosis that is made by clinician. Okay. Another important aspect that we all must know is a condition wherein you are allowed to do, you can give empirical antibiotics in cough. There is a wet cough for more than 4 weeks. Child does not have symptoms of coryza. The growth and development is normal. X-ray is normal. Normal physical examination. Considering these 3 organisms, you can give a course of amoxicillin for 14 days. But please remember, when a child gets persistent or protracted bacterial bronchitis for more than 2 episodes, that's a candidate to be referred to a higher center for evaluation. Do not keep on giving antibiotics one after another. So history is very, very important in a case of, when you deal with a child with cough. The age of onset is very, very important. Any neonate with onset of cough in neonatal period is, until proven otherwise, is pathological. So keep that in the back of the mind. Any child who gets the abrupt onset of cough is always foreign body. You keep that in the back of the mind. Whether it's dry cough or a wet cough that lasts for more than 4 weeks, you have to be very, very cautious. When there are upper respiratory symptoms alone, then you can be very safe. If the child coughs at night, you have to ask whether it starts immediately after lying down. Then it's a postnasal drip allergy associated with allergic rhinitis and sinusitis. You can just treat them accordingly. If the child coughs with fits, you have to think about important things like tracheoesophageal fistula or palatopharyngeal incarnation in immature children or achalasia cardia. If the child does not have cough in the sleep, it's a tick cough. History is very, very important in making a diagnosis. Physical examination, complete undressed child, head to foot, thorough examination, repeated examination, very, very important. Always you have to make use of the growth chart. I request every pediatrician who is attending this conference, even though it is cough, you have to plot a growth chart. Failure to thrive, clubbing, warrants further investigation. And always you have to monitor the vital signs. You have to see for hypoxemia. And always look for tonsils, adenoids, pharyngitis, and ear. And these are all very, very important. Looking into whether the stridor is present or not, wheeze is present or not, is very, very important in every child whom you see with a cough. So coming to the age-wise presentation of cough, in neonate and young infants, as I told you earlier, most of anomalies, airway abnormalities, are either birth defects. Many times these mother will come and tell you, every time I breastfeed the child develops cough. You have to think of H-type tracheoesophageal fistula. Sometimes you have infection that's called chlamydia, in which a neonate is brought to you with a cough. So if you carefully look, the mother will have chlamydial infection, vulvovaginitis. The child which passes through via naturalis during delivery will in the first week develop conjunctivitis. If you see a neonate with a conjunctivitis, unilateral conjunctivitis with a lid edema, with a preauricular adenitis, your diagnosis is confirmed. You have to start the child with erythromycin estrolate as early as possible, because if we don't treat this conjunctivitis after 1 week, we will land up in chlamydia pneumonia. That's very, very important. Neonates can do a pertussis. The mother does not have adequate immune protection. They can develop RSV infection. And always in neonatal cough, keep cystic fibrosis, primary ciliary dyskinesia, always in the back of the mind. So in preschool children, vast majority are viral respiratory infection, recurrent illnesses, and in acute episode, you think of foreign body. Always consider under 5 asthma in these children, and always ask for a history of passive smoking, particularly in preschool children, because that's very, very important. Unless the father stops smoking, you will not get the credit for controlling the cough. In schoolgoers, asthma tops the list, and next to that is upper airway cough syndrome, particularly post-nasal drip, secondary to sinusitis and adenoiditis and allergic rhinitis. That comes second in the list. And always environmental history is very, very important in schoolgoers. There may be some construction work going on in the house, or some parents inside the house, or there is a Persian cat that is causing cough. That is very, very important. As I told you, tuberculosis should come in the back of the mind, irrespective of age, neonate, young infant, preschool, school going. Always consider tuberculosis in our country. So here is a situation where you had a 3-month-old child which presented with progressively increasing fever, mild cough, but child is having a tachypnea, breathlessness. Child took OTC cough syrup and paracetamol, there is no improvement. Child came to the referring general practitioner around 4th day. The total count was done 20,000 WBC with Collies, that is 80%. Child was sent home with Cefixime. If you look at this is a young child, 3 months old, with a progressively increasing fever, with respiratory distress and tachypnea and dyspnea, with a polymorphic leukocytosis that swings the pendulum to say that the child has got occult pneumonia. First thing you must do is to take X-ray chest for this child. This child had a left upper lobe pneumonia. Lateral also has to be taken. So whenever you have a child less than 3 months of age with polymorphic leukocytosis, you have to take X-ray chest considering occult pneumonia, or you have to do a urine microscopy considering occult UTA, or you must take blood culture, start an antibiotic considering occult bacteremia. So never start on Cefixime. Cefixime is a drug for infections below the diaphragm where the gram-negative organisms are there. Upper respiratory infections are always gram-positive. Never use Cefixime for upper respiratory infection. That's a carry-home message. So coming to the flow chart, whenever you see a child with cough, you have to take history. That's very, very important. You have to ask for shortness of breath, chest pain. You have to look for cyanosis, see whether there is noisy breathing, there is a feeding difficulty, or there is a wet cough, or there is a hemoptysis, or recurrent infection, or neurodevelopmental abnormalities. If these things are there, you have to directly go into examination for failure to thrive. Look at the growth chart, see whether the child has got clubbing, check the pulse oximetry to look for hypoxemia, auscultate for wheeze. If there are polyphonic wheeze at multiple sites, probably it is asthma. It's a monophonic wheeze at a single site, probably it's foreign body. Look for crackles, look for bronchial breath sound, look for whooping and chest wall deformity. That is, look for whether there is hypotonia, cardiac abnormality, or dysmorphic features. Having done these two, then you can come to a specific cough like pertussis or cystic fibrosis. Then you have to manage the child based on the underlying diagnosis, confirm and diagnose. If it is a non-specific cough, but these findings are all negative, the history and the examination are all negative, what you need to do is you have to do a watchful observation. So avoid passive smoking. Consider foreign body in such situations, because in foreign body, sometimes the foreign body child may start having cough. As the days progress, these receptors in the larger lumens like trachea, bronchus, they become adaptive, because they over a period of time they abate, they do not respond to the foreign body that is inside. Cough which was there earlier days, as the days progress, cough disappears in a foreign body. Please keep this in the back of the mind. And there are no specific symptoms. If needed, we can do some basic investigation. I'll tell you later. So in a cough, there are only two conditions where you can do empirical therapy. One is, as I told you earlier, when there is no coryza, when there is a wet cough in a well child, growth and development normal, X-ray is normal, clinically normal, cough, wet cough more than 4 weeks, you can make a diagnosis of protracted bacterial bronchitis and give amoxicillin for 2 weeks, number one. And if there is a dry cough of more than 4 weeks and child has got markers for, as I told you, the evidence for hyperreactive airway disease, exercise-induced nocturnal, atopy, family history. When these things are there, you can give a trial of inhaled corticosteroids for a period of 4 to 6 weeks. Then we can follow up accordingly. So these are the two areas where you can give empiric therapy. But for this, there is no role of empiric therapy in cough. So you must remember, you have to have an index of suspicion and you have to refer them early to pediatric subspecialists, particularly when there is a foreign body or there is a congenital or developmental defect, or where there is a persistent hypoxemia, even after treating hypoxemia persistis, or unresponsive with antibiotic microbial therapy of more than 2 weeks, or a partially or a prolonged course of illness more than 3 months. When you suspect cystic fibrosis or primary ciliary dyskinesia, all these things you have to refer them early. So there are some vital clues by looking at the sputum. Please remember, sputum is a valuable tool, particularly in adolescents. If you have a productive cough, look at the sputum. If it is clear, probably it is asthma. If it is cloudy, it is infection. If it is purulent, at the same time foul smelling, probably you are dealing with bronchiectasis. And a purulent, non-foul smelling with a birth, you see since birth, with chest deformity, with clubbing, you have to think of cystic fibrosis. Whenever you suspect cystic fibrosis, at the bedside, even inside your clinical chamber, we can do this simple bedside test. Sometimes the sputum looks red. It indicates that there is a bleeding from the airways. Or another important thing, there is a Klebsiella infection. Or you have to consider hemosiderosis. Because Klebsiella infection is notorious infection in which most of the time they cough out pink color or a red color sputum. That's called current sputum, red current sputum. Like in interception, you have a red currant jelly. In Klebsiella, red currant sputum. So Klebsiella is notorious for that. So let us come to what investigations, when to do, what not to do. So please remember, the role of X-ray in a simple cough is limited, does not have any role, because cough is a symptom arising from luminal pathology, whereas X-ray will help you to identify if there is a parenchymal pathology like pneumonia. You do it only when you suspect pneumonia or a suspected foreign body. Otherwise, in a simple cough, you are exposing the child to irradiation. Never do cough X-ray for a simple cough. 1 day cough, 2 days cough. Do not do X-ray for diagnosis of wheezing. Wheezing is a clinical diagnosis. And CBC also has got a limited role in cough. When a child comes with 1 day or 2 days of cough, do not do CBC. Whereas a child with a cough of more than 4 weeks, the CBC shows a marked anemia and there is an increased MCSC. For example, more than 10, 40. Normal is 32 to 36. If it is more than 40, you have to consider mycoplasma just by looking at CBC. We do not do IgM or you need not do PCR. Just by looking at CBC, you can make a diagnosis of mycoplasma, provided child has got extrapulmonary manifestations. This means the child has got an anemia, autoimmune hemolytic anemia due to mycoplasma. If there is a marked anemia, there is a red color sputum, and the MCSC is normal, consider hemosiderosis. And if there is a marked leukocytosis in a child who has got paroxysmal cough, consider pertussis. And if there is an eosinophilia in a child who has got dry hacking cough, nocturnal cough with other pointers, you have to consider asthma. CBC plays a vital role, particularly in cough of longer duration. So simple viral illnesses, please remember, do not rely upon lab reports. No CBC, no CRP, no ESR, no Manto for a simple cough. You have to do tests only when it changes the line of management. These tests do not change the line of management. So do not do these tests. Honestly, you are increasing the cost of management. So some of the frequently asked questions regarding cough. A child comes to you with allergic rhinitis and a postnasal drip. Child is a school-going child. Use second generation antihistamine because the first generation antihistamines crosses the blood-brain barrier and affect the scholastic performance. The ideal drugs are 3 in number. They are fexofenadine, levocetirizine, or desloratadine. Fexofenadine is a US FDA approved drug. It's approved. The US FDA has given approval for OTC also. The drug should not be used for children less than 6 months of age. The dose is around 15 milligrams BD, less than 2 years, above 6 months. And between 2 to 12 years, it is 30 milligram BD. Above 12 years, it is 60 milligram BD or 120 milligram OD. Levocetirizine has to be avoided in children less than 2 years. The dose is between 2 to 6 years, it is 0.125 milligram per kg per day. More than 6 years is 2.5 milligram per day. Levocetirizine is a levo form of cetirizine. It is less sedative and low dose is required. Desloratadine should not be given less than 1 year. Dose is from 1 to 5 years is 1 milligram, 6 to 11 years is 2.5 milligram. More than 12 years is 5 milligram. It can be given OD or BD. Please remember, if the child comes to you with chronic cough, afebrile cough, dry cough, nocturnal cough with markers of wheeze, so you can start the child on short-acting beta-2 agonist. As a trial, you can give 1 dose of salbutamol nebulizer. Immediately cough will come down. Then you can prescribe salbutamol. Ideally, what we recommend is salbutamol through inhaled route, or you can give mono pharmacy salbutamol, single ingredient salbutamol alone. Do not give salbutamol with guaifenesin or menthol or camphor or eucalyptus oil or any other expectorant. So it has to be simple, plain salbutamol syrup. Sometimes you get children with common cold, young children with stuffy nose syndrome. The only permitted drug that you can use is normal saline nasal drops. Do not use any other drug for common cold. As I told you earlier, if you treat, it will last for 7 days. If we don't treat, it will last for a week. So if the child is having sleep disturbance, the mother is having sleep disturbance, US FDA approves after 1 year of age the use of first generation antihistamine, that's called diphenhydramine. It can be used with a dose of 5 milligram per kg per day, preferably at night time, or it can be given 8 hourly or 6 hourly. The only drug that is being tested by a lot of randomized controlled trials to suppress the cough, only cough suppressant, is dextromethorphan. If the child has got isolated dry cough, particularly in post-surgical conditions like hernia operation or a cataract operation or any other surgical procedures, shunts, where the sutures may pop up, in order to prevent that, the only drug that is recommended for cough to suppress it is dextromethorphan. It's a US FDA approved drug. It's a centrally acting drug. It can cause sedation. It should not be given for children less than 6 years of age. Dose is 0.5 milligram to 1 milligram per kg per day. Can be given at bedtime or twice a day. Peripherally acting drug, which is not approved by US FDA but approved by Government of India, is levodopa, which has no sedative effect. It has been given about 2 years of age. The dose is from 2 to 4 years. It is 10 to 15 milligram per kg per dose, and 5 to 12 years it is 15 to 30 milligram per dose. It is not kg. More than 12 years it is 30 milligram per dose. It is available as 30 milligram per 5 ml dose. Please remember, these cough suppressants should never be given for a wet cough or for asthmatic cough. It will create more complications. So never prescribe cough suppressant for wet cough or asthmatic cough. Only one indication, post-surgical conditions. So antibiotics in cough is only 3 situations. One is a chronic wet cough. That's where you don't have a coryza, your X-ray is normal, growth and development is normal, no clinical findings, protracted bacterial bronchitis. Second is atypical infection with mycoplasma. Third is pertussis. Never use antibiotics other than these 3 conditions in a child with cough. Never use cefixime for LRI. Always cefixime is for infradiaphragmatic infections where gram-negative organisms are the culprit. So the only drug that is safely recommended by WHO, Pediatric Clinics of North America, American Academy of Pediatrics, Nelson Textbook of Pediatrics for all cough is your honey. It's a good demulcent. Demulcent is something that forms a protective layer over the cough receptors. It is an antioxidant. It increases cytokine release that helps the recovery of cough, and it has got an excellent safety profile. The dose is 2.5 ml to 5 ml. It can be given twice or thrice or HS with warm water. And it should not be given for children less than 1 year because of the fear of botulism. And ideally to use pasteurized honey. So only one drug that you can use safely, recommended by all organizations, is honey. Please say no to cough syrups. Please remember, your vitamin C, guaifenesin do not have evidence. Your herbal cough syrups lack standardization, no rational evaluation for these cough syrups. Avoid codeine in pediatrics. Camphor, menthol, eucalyptus oil, no effective studies are available to use them in your practice. And please tell them to not to use home nebulizer for pediatric age group. Many times the mothers, if you tell them to give salbutamol, they will keep on giving salbutamol therapy until one point where the child will get hypokalemia. Child may go in for cardiac arrest. So it has to be supervised. It has to be inside the hospital or clinic. No home nebulizer for children. That's very, very important. And the last important carry home slide. Please, very, very important message, and this awakening message for all practitioners. Avoid cough syrup in children less than 2 years. Avoid chlorpheniramine maleate and phenylephrine for children less than 4 years. Avoid polypharmacy in cough syrup. A cough syrup that contains expectorant, suppressant, bronchodilator, antihistamine, decongestant, mucolytic, all having different action put in a single bottle, nothing will act. So always use monopharmacy, single ingredient. If you want, use cough syrup for bronchospastic cough, you can use salbutamol. If you want to suppress the cough in a child who has undergone surgery, you can use single dextromethorphan. Do not use polypharmacy, and never give empirical ATT, never give reflex therapy empirically. And please remember to educate every patient who come to you with cough about the need for vaccinations like diphtheria, pertussis, tetanus, measles, MMR, pneumococcal vaccine, and flu vaccine. I request all the doctors who are attending this cough seminar to take flu vaccine because you are a high-risk person for flu. Now there is an outbreak of flu, to take this vaccine. With that, let me come to the last slide. The most important carry-home message of this meeting. காஃபுக்கு சிறப்பு, கொடுக்காமல் இருப்பதே சிறப்பு. நன்றி. So message is காப்புக்கு சிறப்பு கொடுக்காமல் இருப்பதே சிறப்பு. Thank you. So yeah, I see lots of messages in the questions in the chat box. I'll answer one by one. The first question, they asked you about adenoviral infection in children. Please remember, a couple of months back, we had outbreak of adenoviral infection, which is a great mimicker of bacterial infection. So it is otherwise called, it's an epidemic pharyngoconjunctival syndrome. You have, by looking at the child, if there is an extensive exudative pharyngitis with follicular conjunctivitis, with cervical adenopathy and preauricular adenitis coming in bouts, lots of children in the family or in the classroom having similar illness, it is until proven otherwise, it is adenovirus. You may not do RT-PCR. Combo of extensive exudative pharyngitis, follicular conjunctivitis, cervical lymphadenopathy with preauricular adenitis. Sometimes they do have UTI symptoms. Urine puzzles should be more than 10. If we do culture, it will be negative. Like Kawasaki, it's called sterile pyuria. They can have a pertussoid cough. They can present with 4 weeks of cough, resembling pertussis. If we do CBC, it will be high. Total counts will be high. Polymorphs will be there. CRP will be high. You will be tempted to start on antibiotics. Do not start antibiotics. Sometimes in the eye, apart from conjunctivitis, there is a keratitis. You have to send them early to ophthalmologists because they may lose vision. So in severe cases, they can develop bronchiolitis obliterans. We had an opportunity to treat one child with a drug called cidofovir. We imported from US. We gave that. So otherwise, adenovirus is a diagnosis which you can make by applying your knowledge, what you have studied in your undergraduate curriculum. There's another question about chlamydia pneumonia in children, particularly in neonates. Please remember, whenever you see a neonate with unilateral conjunctivitis, lid edema, it's a clue. Think of chlamydia. 1 week later, these children will develop pneumonia. So you start them on erythromycin acetate 1.5 milligram per kg per dose. Please educate whenever you give erythromycin or azithromycin to a neonate for chlamydia or mycoplasma or pertussis. You have to educate the parents about the pyloric stenosis. If any child develops a projectile vomiting or a vomiting after these drugs, it has to be stopped and they have to come back to you immediately. That's very, very important. There is a question about achogenic Pharma wrinkling test, bedside test for cystic fibrosis. It's very, very simple test. What you have to do is, if you have any child who has got a wet cough of more than 4 weeks with failure to thrive, child has got chest deformity, clubbing, since birth it is there, you can do this test called cystic fibrosis bedside test called achogenic Pharma wrinkling test. What you do is, take a lukewarm water in a cup that is around 40 degrees Celsius, immerse the hand of the child for a period of 2 to 5 minutes. After 2 to 5 minutes, take out the hand, look for wrinkling or white papules in the hand. If it is positive, it is wrinkling is there, white papules are there, it means the child has got either cystic fibrosis or a carrier state. Normally, generally, it takes 10 to 15 minutes for the wrinkles to form. So this is called a bedside test called achogenic Pharma wrinkling test. You can start doing it in your consultation room from tomorrow. There's another question about influenza. Please remember, influenza is a disease that commonly outbreak during monsoon. Now entire monsoon, entire Tamil Nadu, because of the rains, lots of influenza. Many children come to you with severe sore throat, dry hacking cough, high-grade fever, and a severe muscle pain, sometimes with watery diarrhea and vomiting, abdominal pain. These constitute as called influenza. Influenza can be due to A or B or C. If it is due to B, you can have a muscular pain. Most of the time, A, you have diarrhea and stomach pain, vomiting. So you have to categorize them into A, B, C, and C. More than 90%, 91% are A, They do not require any test, no treatment for with oseltamivir. Only they have got comorbid symptoms like chronic disease of the heart, chronic disease of the kidney, chronic disease of the liver, or chronic disease of the lungs, or they got hematological abnormalities, or they got immunosuppression acquired like HIV, or a passive on steroids, or the child is obese, or the child is extremely low age, less than 2 years of age. It's adults more than 65 years of age. Pregnancy, these are called high-risk situations. In these conditions, the patient has got influenza. You are justified in making a diagnosis of category B influenza. You can give oseltamivir. So oseltamivir syrup is available as 12 milligram per ml. The dose I'll tell you later. So you can check the book. So oseltamivir is indicated only in less than 9% of the cases. In severe cases where you have a hypoxemia, cyanosis, hypotension, shock, seizures, severe dehydration, or child has got loss of consciousness. These conditions, they are called category C. These conditions, you have to refer them to higher center like ours, where we isolate them. We take RT-PCR in one hand, we give oseltamivir in another hand, we inform the health authorities, we start the child on ICU treatment with oxygen, with antiviral, and here anticipating ARDS and pulmonary sepsis and pneumonia, we give third generation antibiotics. With all these things, we can reduce the mortality to practically zero. So only one thing about flu is that you can prevent flu by giving vaccination to all children, particularly during this outbreak. There is a recommendation by WHO and also Government of India and IAP about these flu recommendations. Please go through that. That's if there are any questions, other questions you can unmute and then ask questions. You can unmute and ask questions. Admin, you can allow them to unmute. Admin, you can allow them to unmute. Sometimes you can have dry cough initially, then becoming wet cough. Only thing is what started in the upper respiratory can descend to lower respiratory. This is normal. So whenever you have a wet cough, you need not worry. Look at the growth and development and other factors. They are normal. You can treat it as a simple cough. Even in a child with failure to thrive with a cough, it is not safer to start empirical antibiotics. It is not an indication to start antibiotics. It is an indication to extensively investigate, not to start on antibiotics. As I already told you 2 times, protracted bacterial bronchitis has to be treated with amoxicillin 50 mg per kg for 2 weeks. Sometimes if the child has got a hyperreactive element, you can use budesonide in a post-viral cough. Somebody has asked about levotropropazine. Please remember, as I told you earlier, that's a drug that acts peripherally. It does not cause sedation. It is not indicated for children below 2 years. It is not recommended by US FDA, but approved by DGJ India. The dose is from about 2 years, between 2 to 4 years is 10 to 15 milligram per dose. 5 to 12 years, it is 15 to 30 milligram per dose. And more than 12 years, 30 milligram per dose. So it can be given twice or thrice a day. So please remember, this is not per kg, it is per dose. And do not use this drug for any wet cough. Do not use this for asthmatic cough. This is only one indication where you can do is post-surgical cough suppression. As I told you, cough is a protective reflex. It should never be suppressed. So do not use it routinely for all coughs. That's very, very important. Yes, sometimes we do see children with Cushing's. Dr. must have prescribed prednisolone syrup for one course, and sometimes they keep on buying these syrups, steroids repeatedly, and child may come with Cushing's syndrome. Adrenaline is used for severe croup or in asthma. As I told you, 2.25%. Dose is 0.5 ml with 2.5 ml of normal saline and then give. So very difficult to convince patients about adamant patient to want some syrup. So what you need to do is you have to tell them the science behind this. Sometimes I show them the Nelson textbook of pediatrics. I tell them my book says no, don't, and I will not give. Sometimes I'll tell them I will not give for my child, and your child is also like my child, I will not give. And if everybody, all the doctors who are attending this conference say that I will not give cough syrup, even if they shop, they will shop in a doctor who knows, who is knowledgeable, will not give syrup. So that's the idea of giving this, sharing this knowledge with all the doctors. Ambroxol does not have any role in wet cough. So in the child less than 1 year of age, I told you no cough syrup below 2 years, no honey below 1 year. So in those children, best cough syrup is your mother's milk. Keep the room warm. The room temperature is inversely proportional to the cough. So keep the room warm, moist, warm. And then most of these cough syrups, cough in young children, they are self-limiting, they will settle down. Make sure you don't put the child in totil. That will trigger the cough, and see for any household irritants. Sometimes they will be keeping these sambrani, incense sticks, all those things in the house. Newborn will be coughing, young child will be coughing. You remove them, the cough will go. Less than 1 year of age, no drugs, only normal saline nasal insulation. Okay, when there are no questions, we can close the. So probably there is one question about pasteurized honey. Most of the time, sometimes they will bring in a cycle, they will sell you honey. They are all adulterated honey. And sometimes you can get it from a tree branch that is unpasteurized honey. They can contain some spores because it is all collected from the honeybee, from the honey bees goes and collect from the flowers. They can contain spores. Like pasteurization of milk, honey has to be pasteurized. Pasteurization is a process in which they heat the honey to high temperature, suddenly cool it down. Even the spores get destroyed. So that by doing that, you can avoid botulism. Clostridium will be destroyed, so you can avoid botulism. So always look for whenever you buy a honey from a standard, this one, whether it contains pasteurized. pasteurized honey, Agmark honey, like that. Standardized honey you have to buy. Yeah, as far as possible, coming to the use of second generation antihistamines, try to go for non-pharmacological measures than giving these second generation antihistamines. As I told you, many of the drugs are recommended for children, only older children. So never try to use anything below 4 years of age. Thank you. So never give any syrup that contains salbutamol with other ingredients like guaifenesin or ambroxol or decongestant or any other preparations. Always you go for a simple single ingredient levosalbutamol syrup. Never use polypharmacy. In influenza, the cough takes at least 2 weeks for the cough to settle down. Most of these children who cough very badly are hyperreactive airway children. So, if they have an element of hyperactiveness, you can use salbutamol, or you can give them nebulizer as SOS in the hospital. So just tell them right from the beginning, in influenza, incubation period is 2 hours, fever is 2 days, cough is 2 weeks. They will know that by second week it will settle down. இப்பதான் சொன்னாங்களா? Am I audible? கேளுமா. Hello. Yeah. I'll ask them to unmute. No, sister. இவர் கூப்பிட்டு unmute பண்ண சொல்லு அந்த admin. I request the admin to allow all the delegates to unmute. Yeah, you'll be unmuted. You can ask questions. So that's a question about what to give for running nose and a dry cough. As I told you earlier, just allow the nose to run. They are very particular that they want to stop the running nose. Tell on the funny side, you have to tell them as long as there is a nose, there will be running nose. So nothing to worry. Most of the time it will settle. If not now, it will settle down later. Most of the time they go shopping, the third doctor or fourth doctor will get the credit. So you must pray God that you should be the third doctor. So do not give any medicines. So there is no brand as pure honey. You have to check in the shop to get it. Montelukos does not have any role in cough. as of the recommendations now, for cough, it is adrenaline has to be given in dilution with normal saline. So, since there are no questions, I'll ஏமா சொல்லிட்டியா அந்த phone எடுத்துட்டு வா. Admin, please unmute others. ஆமா. இது அவங்க எல்லாத்தையும் அன்மியூட் பண்ணுமா இருக்கவங்க எல்லாத்தையும் அவங்க எல்லாத்தையும் அன்மியூட்டே பண்ண முடியல. நிறைய பேர் இருக்காங்க, அவங்க கேள்வி கேட்கணுங்கிறாங்க. They want to ask questions, but it is not unmuting.
அவங்க கிளிக் பண்ணுங்க சார். பேரண்ட்ஸ்
எல்லாத்தையுமே அன்மியூட் பண்ணணும். அன்மியூட் ஆல் பார்ட்டிசிபென்ட்ஸ் அப்படின்னு வரணும்.
லிஸ்டிங் சார்.
இந்த லிஸ்டிங் தான் இருக்கு, இதுல போய் பார்க்கலாம்.
ரஞ்சித் வருசலா
கூப்பிடு.
Sir, I done that unmute for all the members, sir.
Yeah. Now, those who want to unmute, you can unmute yourself and then ask questions. Those who want to ask questions can unmute yourself and then ask questions.
Good evening, sir.
Good evening.
Session was very nice, sir. Thank you for enlightening us.
Yeah.
And the role of nebulization with normal saline and 3% normal saline or duolin, which are commonly prescribed among all general practitioners. What is your take on this, and is it worthy to use?
Yeah. Ideally, if you are using a nebulizer, you can use it with normal saline for children or for children who are very young, because the smooth muscle development is not there. So your salbutamol will not act. For older children who have got a bronchospastic cough, it's just salbutamol alone is sufficient. And your dose will be titrated by the tidal volume. So there won't be any toxicity. And your 3% saline, when you are using, sometimes it can by itself can produce reflex bronchospasm. So normally we use 3% saline for induced sputum. When older children can bring out sputum, younger children, they will not bring out sputum for doing tuberculosis tests. Those conditions those children we do give priming of salbutamol, then give 3% saline nebulization, then the sputum will come out. So it is used as a mucolytic for 3%. Generally, we use normal saline nebulizer and a single ingredient salbutamol nebulizer for older children for a bronchospastic cough. Okay. When you admit those children and when you have a child with hyperactive airway disease acute exacerbation of asthma. You can use inhaled nebulized corticosteroids, and you can use ipratropium bromide also. Yeah.
Sir,
Thank
good
you.
evening,
Any other
sir.
questions?
Sir, good evening, sir.
Yeah.
Sir, Dr. Perisami, sir, from Salem.
Yeah.
Sir, it's a
Thank you.
session, sir.
Thank you.
Sir, doubt the role of glycerol, sir. Number one, role of glycerol, sir. It's a few companies coming out with glycerol. Role of glycerol for crop suppressant, sir.
There is no rules, doctor. Glycerol is available at. Glycerol is used as a demulcent. Instead of that, you can instead of that you can use honey. Honey is a good demulcent.
Okay.
It's a safety profile, and there is no toxicity. It is available at home, so you can use honey with warm water. The younger child 2.5 ml 3 times a day. Older child 5 ml 3 times a day with warm water. So do not use glycerol. There is no indications. There is no recommendation from any scientific body.
Okay. Phenargon in less than 1 year. As well as promethazine less than 1 year child for cold.
Preferably for not for cold. If the child has got travel sickness or motion sickness, you can use it. Preferably promethazine is not recommended, sir, for a cough and cold.
Okay.
Most of the young children who have cough and cold, best is to keep the room moist, warm, breastfeeding, hydration, and avoid triggers. Give normal saline nasal inhalation. Just wait and watch. It will settle down.
Okay, sir. Is there any need of mixing with the normal saline in respiratory, sir? Somebody still no need of mixing normal saline for respiratory.
No. Always what in nebulizer what we use is Bernoulli's principle. For Bernoulli's principle, jet of air comes through the tube and then it goes through the volume. Around 4 ml of volume of fluid should be there. So if you use this salbutamol solution alone, it will not be equal. So you have to add around 2.5 to 3 ml of normal saline and then do it. Then only Bernoulli's principle will be there. The particles will be broken to 2 to 8 nanometers. It will go to the area where it is required to get deposited. So you have to use either under dilution or over dilution. Bernoulli's principle will not act. You will have a larger particles or a smaller particles that is deposited in the mouth. So for adequate nebulization, you must use adequate volume of solution by diluting with a normal saline. Respules with a normal saline. You must have at least 4 ml.
Okay. They come at 2.5 ml only. Okay.
Yeah. 1.5 ml.
Okay. Thank you, sir. It's a wonderful session, sir.
Thank you. I think there is one doctor from Ooty, Atti. Hello, doctor. Please don't talk among yourself. Please do not talk among yourself. Please mute yourself. If there are any questions, there are no questions. We'll close the meeting. Thank you. Thank you. Thank you for the wonderful meeting. Thank you so much. Thank you, everyone. You can leave your feedback in your up-to-date group.